Hi, it's Dr. Centeno, and thanks so much for joining us today to You've Got the Power. And we're going to be focused today on an interesting topic, and that is which alar ligament controls which lateral bending movement. And what I mean by that is that we'll often get digital motion x-rays on patients to see if they have craniocervical instability or C1-C2 instability, also called atlantoaxial. And the question comes up, which alar ligament would allow C1 to move laterally on C2, or what's called C1-C2 overhang. So let me share my screen and we'll get started with that. As usual, I'll go ahead through a couple slides, start the topic rolling. You can ask questions about the topic. You can ask questions about anything you want to. So let's get to share my screen. And I'll start that presentation next. Okay, so which alar ligament causes C1-C2 overhang? And I'm going to get a pen here so I can draw and do what I do there. So just a brief overview of just a few of the upper neck ligaments. And this is just a few. There are ligaments in front of this, ligaments behind this as well. So if we look in this front view, what we see here is this is C1 and this is C2. And C2 has a projection called the dens, which comes up this way. And what comes off of the dens is this alar ligament off to the right and left. So it acts as almost like the dens. If the dens were me, then the alar ligament is represented by my arms going up and grabbing the skull. So it bonds the skull to C2, and it sandwiches C1 in there between the two. Obviously, there's going to be some force there to keep C1 in place. C1 also has, or the atlas fits into the skull through the occipital condyles there. So it's generally not going to move as much. Now, so that's the alar ligament. There's also a transverse ligament, which is not shown here. That's like the seat belt for the dens that goes around there, and many, many other ligaments. But today we're going to focus on alar. Now, a digital motion x-ray or a DMX is simply where there's a live video of your neck bones moving. And we're trying to see if things move too much. And since instability is a dynamic concept, obviously dynamic imaging would be a more accurate way to see if it's there. Now, this is what a DMX looks like in real life. And you can see here, I'll kind of draw out. So this is going to be C2. So that's C2. And this is going to be C1. So that's one lateral mass of C1. And then the other one is way over here. And that's also the other side of C1. Now, what you can see here is these two don't line up. C1 is overhanging C2. And that's what we call C1-C2 overhang. Now, that's the way it looks in real life on a DMX. This is the way it would look if I just sort of draw a representation of it to make it look a little bit easier. So if you laterally bend and we're looking through your open mouth and we see C1, C2, everything should stay aligned. And the max on this measurement at those two corners of C1 and C2 is 2 to 3 millimeters. Now, if you've got overhang, here C1 has shifted this way. C2 has stayed put, and now these lines don't match up anymore. So that's called C1-C2 overhang, and we can measure that distance from here to here and look at the number of millimeters that is and see if you meet the criteria for craniocervical instability. Now, the big question is always, let's say we're in a situation and we treat a patient, and I just had this happen this week. We had a patient who had a good amount of overhang, 5-6 millimeters. We did the first PICL procedure, and one side went from about 5 millimeters to normal, so no more C1-C2 overhang, but the other side didn't change much. So the question became, which alar ligament should we be targeting more in that second procedure to try to get him more complete relief? And biomechanically here, if C1 and the head move together, and sometimes they don't, but 90% of the times they do. So assuming this moves with this, meaning C1 and C2, or C1 and the skull move together, then as you laterally bend, this alar ligament comes under stretch if this starts to go that way, and this other alar ligament, the opposite alar ligament of the overhang, because the overhang's over here, is slack. So basically, the conclusion is that it's the same side as the overhang. Now, there could be caveats to this, like if C1 isn't moving with the skull, which is more rare to see. But for the most part, it's the alar ligament on the same side as the overhang that's responsible for that overhang. So again, same side alar ligament as the overhang is the culprit, and that answers our question. So that's it for my slides. Let me see if there are any questions here. And let's go back and see what we got. Submitted advanced by Jimmy O'Neill. If alar ligaments are deemed unremarkable in multiplanar MR images of the cervical spine, attained at 1.5T, slicing sequences were obtained in neutral, 30 leftward, 30 rightward rotation, then what could be the cause of 6.9 millimeter and 5.0 millimeter overhang during open mouth APDMX? Would an upright MRI be better as it adds vertical load to the ligaments? Well, the alar ligaments aren't loaded vertically. So if you're sitting, they're going to be unloaded, actually. If you were hanging upside down, they'd be loaded. So that's not going to work. Jimmy, I think the problem that you're bringing up is a common one, and that is there's a big difference between structurally looking at a ligament on MRI and actually testing to see if the ligament is doing what it's supposed to on DMX. So even though there can be a correlation between those two, sometimes they're not linked at all. In addition, the question would be, how well did they image those ligaments? They're not easy to image. Most radiologists haven't looked at them more than a couple times in their career. And so I'd have to look at the MRI to see if it's actually normal. But in the interim, it's not uncommon to see a ligament that looks structurally intact, but when we stress it, it doesn't do what it's supposed to do, which is what DMX does. So I don't think that going to an open movement-based MRI is really going to work or add much in that case. Could you inject tendons that attach to the atlas in the head? Yes, Megan, I just saw a patient yesterday where that's the game plan. So yes, we do that all the time. Bonnie, my hematologist cancer doctor told me yesterday that I may have leukemia. I read that PRP actually may treat cancer. Have you heard anything about this? No, Bonnie, I know nothing about PRP treating cancer, and I wouldn't put PRP personally in that category. So I would say not a real thing that I know about. Cian, what ligaments control extension? Yeah, Cian, I think we've talked about that before here. And I'll see if I can bring up that ligament diagram again that we looked at last time. Let's see here. It may take a little bit because there's a lot of data in that file, but I will bring it up. Okay, so let's share the screen here. And let me So when your head goes into extension or your neck goes into extension, it's going to be all of these anterior ligaments that control that motion. Now, muscles too, because there's lots of muscles up here. But things like, so if we go out to in, because the outer ones would have the biggest lever arm advantage. The SS or the SAAOL is the outermost one, which is really just an extension of the anterior and longitudinal ligament up. Then you've got the AAOM, and then you've got the apical ligament, and then the cruciate ligament, and then the tectorial membrane. So those are all things that control extension. Okay, let's get back to questions here. I had C1-C2 overhang on the right side by 3, measured on x-ray through mouth with head in side flexion. I had posterior PRP at C0, 1, 2, 3, 4, and after 3 months, I'm thankfully 70% better. This means something other than Alar was causing the overhang and is now healing. So if you had PRP into the facet joints, that generally won't move the needle on overhang. So realize that the overhang is due to damaged ligaments, and then the joints start getting beat up due to the instability. And so getting the joints treated with PRP is great because that'll help them feel much better, maybe help them catch up to the wear and tear, but it generally won't change the overhang part. So in all likelihood in that situation, if you get another measurement of overhang on the DMX and it's still there, which it usually is, then at some point those ligaments are going to have to get treated. Now, every once in a while, we will see a patient, maybe 1 in 5 or so, where we can tighten down some of these posterior ligaments while we're injecting those facet joints, and that will reduce the overhang, but usually not in most patients. Jennifer, my son is laxing in both alar ligaments. He's been able to hold alignment. His transverse ligament is also compromised. He has many symptoms and disability related to the instability. Can PRP injections help stabilize this? Jennifer, generally what it takes is that picl procedure, which is the only one that can get directly into those ligaments. So let's talk a little bit about that, because that's, I think, a good topic to discuss. So I'm going to share the screen again here, and we're going to go back to that same presentation here. Let me get rid of all the drawings there. So the alar ligament is going to be part of this cruciate. So it's going to be deep in here. And when we're doing PRP injections from the back, we can get to things like the facet joints. We can get to this PAOM, the ligamentum flavum. We can get to the nuchal ligament, which is up here, the vertebral-dural ligament, which is down here, the supraspinous, interspinous ligaments that are down there. So that's a posterior injection. But we need to come from the front in order to get the alar ligament, which lives in the middle here. And that's that picl procedure. And for that, we usually use bone marrow concentrate. So yes, they can be treated and injected, but we have to come from the front and generally use bone marrow to do that rather than from the back like a PRP injection. Okay, Tyson, have you treated any dentists for cervical instability? My wife is a dentist and has lots of neck pain. Anything common you see with dental providers? Well, lots of dentists have neck pain. Obviously, that may or may not have anything to do with CCI. That can be due to lots of different things, from overloaded muscles to worn out facet joints to painful discs, disc bulge, irritated nerves, et cetera, et cetera. So always happy to take a look to see what's going on with, for instance, your wife's MRI, or get on telemedicine with her. But yes, lots of dentists have lots of neck pain because, as you know, as you probably heard, they'll sit in one position and they'll turn their head all day. It's not really easy on the neck at all. Let's see here. Regenexx, submitted advanced by Harry Winston. Can more than just the Alar ligament be responsible for C1-C2 overhang, for instance, arthritis in the C1-C2 joint itself? Arthritis in the C1-C2 joint is certainly not going to help. There are other things that can help to reduce that motion, like the capsular ligament around C1-C2, as well as other ligaments like the Atlanto-Occipital ligaments or the intertransverse ligaments down here. And all of that can be tightened down by the nuchal and vertebral dural ligaments back there. So yeah, there are other ligaments that are responsible for it. We're just focusing on the big kahuna here. And if you have C1-C2 arthritis, that's going to cause some degenerative instability. Great. So Jennifer, if you want to get on the schedule to take a look at that, I'm going to go ahead and put Carla's email down here. She's my personal assistant, and she can, if you reach out to her via email, so that her email is going in the comments, she can help you get something set up. We can take a look at all that and see if your son's a candidate for this kind of treatment. I showed this paper, Diagnostic Asher VF. That's the Freeman-Katz paper to Spinal Consultant, which explains how to measure overhang and significance. He would not accept that. Where the medical papers are there to help with such discussions. Yeah, I don't know what to tell you there at all. It sounds like you're in the UK system. In my experience, the closest analog we have to the UK NHS here is our Kaiser system. And, there's a real problem in that system for doing additional work. So I'm not sure what to tell you. That's probably the best normal, abnormal upper cervical imaging paper we have. It's better than anything the neurosurgeons have produced to date. For instance, looking at things like Grab Oaks, clavoaxial angle. Those we only know sort of through long history and experience. And in situations where there's usually fracture or extremely severe upper cervical injury requiring emergency surgery. That's actually the only data we have in these kinds of CCI cases where someone's head's not fallen off. So don't know what to tell you there as far as trying to get an NHS consultant to listen. There are some excellent surgeons in Europe, who Dr. Gillette in Spain, who may be able to help. Obviously, he'll understand what that means. He may have his own ways and for looking at CCI as well. But at least you have someone there who understands which end is up when it comes to upper cervical instability. Bonnie, hematologist, cancer doctor. Yeah, I got that. Phil, I have some moderate stenosis at C456. Would posterior PRP help with this, as I'm due for my second procedure in a few weeks? Yeah, I mean, that's something to talk directly to your doctor about. The question is that symptomatic and does it need to be treated? And that's obviously only something your doctor can tell through a history and hands-on exam. The clivo-axial angle, or CXA, on extensions measuring 142, normal range is 150 to 180. What's causing that? I don't know that we have normal clivo-axial angles for flexion and extension, or that that's well studied in this kind of patient population. So clavoaxial angle in neutral, I think, is something we can look at. And that's a different set of numbers. That's more 130 to 135 to 150 to 155. But as far as clavoaxial angle and flexion extension, if that's ever been published, it's going to be focused on much more severe scenarios where someone's head is falling off and they need emergency surgery. So it's not really talking about the same thing as we're talking about here. Regenexx has been advanced by Maria Cole. If DMX not available in the country we live in, what else can show C1-C2 overhang? You know, we've seen a lot of patients in Europe. They get an open mouth view, and then they do maximal, lateral bending. So I think what I'm going to do, since this question comes up a lot, is this coming Monday, I'm going to try to do one of these on that topic. How do you get something like a DMX done if you're in a country that doesn't have DMX? And I'll walk you through it, and I'll probably create a little sheet of paper that you can, maybe I'll reference to and you guys can go to hand somebody at a European imaging center to say, this is what I want you to do. Because I think it's possible. It's not going to be as good as a DMX, but for most patients, it will probably be good enough. So, so Carol, who's listening, or Carla, if you're listening, just remind me that this coming Monday, that's what we'll be doing. We'll call it something like how to get a DMX if you live in a country without a DMX, or something like that. But I think we got to address that one on this show, because that question's come up a bunch of times. Anya, I actually have a very complex situation: instability and severe pain in my whole spine, muscle pain, problems with swallowing, cognitive issues, joint pain. I have to lay down for 20 hours a day. Possibly have EDS. Think during your London regenexx clinic. I wanted to have a virtual consultation with you to determine the treatment plan, since my case is very complex. And then have a consultation with the doctors at London regenexx clinic. I think it's better, Anya, for you to go directly there, because they're going to be able to tell much more through things like a hands-on physical exam that I'm not going to be able to do. So that would probably be the best place to start, is just to see those guys directly. Unit, my DMX shows C1-C2 overhang of 9.7 on the right, 5.4 on the left, but all my pain is on the left side. Can you explain why? Overhang and pain shouldn't really correlate there. Overhang doesn't really cause pain. What would cause pain is the other things that happen as a result of overhang. So, for instance, the lateral spinal cord getting banged into. I think last show we talked about the trigeminal nucleus here and how that can get banged into, causing facial pain when there's C1-C2 overhang. The lateral spinal thalamic tract is also there, that can also get banged into. The joints themselves can become painful and arthritic. So overhang shouldn't be related to the side of your pain, but what happens in as a result of the overhang. So yeah, a bulging disc from C3 to C7, is that due to instability from upper, causing them to compensate and bulge outwards? Not usually, no. It's probably, most commonly it would be due to loss of curvature in the neck, putting more weight on those discs, and or wear and tear, and or genetic issues, etc. But generally, upper cervical instability shouldn't affect the lower cervical disc. Unit, I have excessive axial spinous rotation. That just represents laxity of the alar ligament and other ligaments. Let's see here. Mike, how many millimeters of ADI, if any, can be corrected by ideal biophysics correction? Well, I think we're talking about different things here. So chiropractic biophysics is putting the curve back in the neck. The atlantodental interspace is the amount of space between C1 and C2 up front. Now, in people that have a problem with the transverse ligament, when they look down, that ADI or Atlantoidal interspace opens up, and that leads to high ADI like we're talking about. Now, if you go and get the curve back, the good news is you can take weight off of that area, but it's still going to be loaded when you look down. One is instability, meaning when it's loaded, it moves too much. The other is taking the weight off of the area, and that's more chiropractic biophysics. Mike, likewise, how much side slippage? Again, Mike, usually we're not talking about treating these ligaments that way. We would be talking about taking weight off of them, and maybe that results in the ligament healing. But we're really not talking about trying to fix the ligament directly with chiropractic biophysics. Now, we have seen through Dr. Katz's practice, for example, we've seen people who've gotten their curve corrected who over time heal these upper cervical ligaments. And that's obviously a fantastic thing. That means we don't have to do anything other than let the body heal itself. So that would be more the approach. Hey, Evan. So that's the famous Dr. Katz there. Dr. Katz does all our DMXs. He treats many of our patients. Evan's a fantastic provider. And so it's great to see him here today. Jennifer, we had DMX images sent to Lee this week and are waiting for review to set up a consultation with you. Yeah, you can generally go faster if you reach out to Carla. She can kind of cut through the red tape, if you will, pretty quickly. Sian, I went to Manchester Med-Cerna Center Flexion Extension MRI. They reported back there's a minor loss of cervical lordosis. Healthcare system sucks in the UK, no digital motion X-ray here. Yes, Sian, like I said, I think it's a little bit like our Kaiser system. Our Kaiser system is not really the best. Hey guys, I'm going to turn the lights on in here just to make it a little brighter. I don't know if that's any better or not, but maybe a little better. But yeah, I would tend to agree. My niece lives in London. She went to Cambridge, and she's experienced it all firsthand. Liam, I had actually an idea of taking finasteride, 1 milligram daily could negatively impact healing from PRP, PICL. Yeah, I wouldn't do it. It's a testosterone blocker. That's how it works. So number one, it's probably not super healthy in men to block testosterone. And number two, we do think that can have an impact on male mesenchymal stem cells. So I wouldn't go there. Again, can bulging disc cause instability or not? Bulging discs are a result of degenerative disc disease, and degenerative segments, disc segments, can get sloppy movement or degenerative instability, but that would have nothing to do with creating a cervical instability, or very little. Anya, thank you for the response. I met before traveling to the UK. I wanted to have a virtual consultation. Yeah, so again, Anya, I think it's far better to spend time with those guys there because they can do a hand-on evaluation. They can see much better what's going on in person than I can, obviously, over this kind of thing. Phil, can excessively tighten down muscles of the neck, such as scalenes and SCM, contribute towards overhang? No, it's more the opposite. Overhang and instability would cause excessively tight scalenes and SCM, not the other way around. Unit, how can one know the actual ADI for their DMX? I don't see it on my report. Yeah, I don't know, Unit, who did your report, but it certainly can be measured, and that's not hard to do. When I turn my neck to the left, it's restricted. I feel like I'm choking. What usually causes that? That could be due to things moving around too much in here, irritating the anterior longitudinal ligament, longus coli, the muscles of swallowing, etc. Realize there's only about that much tissue between where you swallow and where your neck bones live. Ravati, I have about an inch of area of swollen nerve behind the upper part of my ear and my scalp. About an inch of area of swollen nerve behind the upper part of my ear. Yeah, that's generally the lesser occipital nerve area. And that's a common one that gets irritated by the sternocleidomastoid coming up. When the sternocleidomastoid, these front muscles here get too tight. And so that can really cause problems. It can cause headache and other things. I'm just trying to fix something here. So yes, that's something that can definitely be an issue. That's the lesser occipital nerve based on your description. Try to add some more light here. I hope that helps or makes it worse. Cian, should I go to London Clinic for the anterior ligaments? You may want to ask those guys if the anterior ligaments. Not sure what you mean. They don't do the PICL procedure, and the only way to get to the ligaments we're talking about, and I understand what you mean based on your last question, is the PICL procedure. So they won't be able to help you there with those ligaments. So not a possibility in London. The only place you can get that would be in Colorado here. Or should I go for surgery in the UK? Obviously, that's a personal decision you've got to make. Big invasive surgery or not. I can't answer that one for you. Obviously, I don't know your specifics of your case. Liam, can ADI be sent on DMX or MRI only? No, ADI is more accurately determined on DMX. It can also be seen on flexion extension x-rays. It's less commonly seen on functional MRI simply because of the way the MRI shows the cortex and the trabecula of the individual bones. It's harder to measure, but much, much easier to measure on flexion extension radiography or DMX. What usually causing bad head pain vibration from just walking, taking steps, and turning head sideways? Did a lumbar puncture 10 years ago? Is terrible head pressure, never went away, no patch. Well, that could be a dural leak from how you're describing it. So obviously you'd want to get a blood patch at that site of the dural puncture. That sounds like perhaps something you should investigate with some of the local doctors there. Unit, do you think HBOT would help her after the PICL? Unit, I don't think it'll hurt. I don't know if it'll help, meaning there's no research showing that HBOT will help ligament healing after bone marrow concentrate has been injected. So I don't know if it'll help, but I don't think it'll hurt. Jennifer, facial swelling presents when the upper cervical vertebra not in alignment. What would be the correlation? I know about facial swelling. We can, excuse me here. We can certainly see facial pain. And if you look at last week's video, there's a video on that and how that works, where the trigeminal nucleus can get banged into and cause trigeminal neuralgia. So perhaps it's related to that, or we're talking about that. I'm not 100% sure. Can thoracic outlet syndrome or anything in the front of the neck be the root cause to instability? No, it's the other way around. So again, instability would lead to tight scalenes, which can lead to thoracic outlet syndrome, but not the way you're describing. Okay, guys, any other questions? Here's Anya. Does PRP into the south help with spinal instability, instability that is lower than C0, C2, or does it only help with arthritis or other ligaments need to be injected to help with instability? Yeah, Anya, you've got to do both. You've got to, usually you inject both the facet joint under C-arm fluoroscopy with contrast to make sure you're in the joint, and then you also inject the neck ligaments. So standard of care would be to do both of those. Now, obviously, if you just have facet arthritis without instability, then you would just inject that arthritic joint. Sure. Other questions, guys, I can answer today? You guys have had some great questions. It's always great to see people thinking, to see those wheels turning in your head. Because again, as I always say, patients that understand this stuff, that learn it, that dig into it, tend to really do much better than those who don't. They tend to make really good treatment decisions, and they weigh their treatment decisions. Should I do this? Should I do that? What are the positives of this? What are the positives of that? Sure, a minute. So other questions I can answer that anyone has out there. I'll give it a few minutes here for a few more questions to come in. Okay, guys, looks like we're going to wrap it up for today then. What we were talking about was which side of the, or which alar ligament controlled which side of the overhang. And it's the same side, or ipsilateral, if the skull and the atlas are moving together. And that is usually what's happening. So certainly interesting thing to look at. Thanks so much for everyone spending the time today. I got two more questions. Let me get to those real quick here. Duck, are you able to inject the posterior lateral occipital membrane more on the lateral side versus the medial side? That can be done, sure, yes. Phil, if posterior PRP done into a mixture of ligaments, joints, some that needed healing, others that didn't, is there any risk downside to existing healthy ligaments and joints? There shouldn't be any risk or downside into otherwise healthy joints. But one of the things I think you should focus on, Phil, or anyone who's getting neck facet injections, is the doctor determines which facet to inject through a hands-on exam. So that's when you're lying face up and the muscles are relaxed and they're pressing on the individual joints one by one, and they're determining which ones are tender, and those are the ones that get injected, obviously. Now, sometimes things can look really bad on MRI. Maybe they're not tender on exam, and so you're injecting those as well. But you do need a hands-on exam to go through those joints one by one to see what's tender. And only the tender ones or the arthritic ones should be injected generally. We shouldn't be injecting normal joints just to inject them, right? Unit, I have to stretch my left arm constantly just to minimize the pain in my left arm and shoulder. Does it have an adverse effect on the neck? Probably not, but I'd probably need to know more about that. Okay, guys, thanks so much for watching. I'm gonna sign off now because I've got a hard stop, and I'll be here on Monday. And like I said, on Monday, we're gonna focus on that idea of how do I get a DMX done in a country or a place that doesn't have DMX accessible. And so what I'm going to try to do is I'm going to try to go over what that will look like so that you can understand it, so you can understand what the directions mean. And then I'll probably put a link to just a paragraph that you can give to the radiology tech to say, hey, this is what I want you to do. So hopefully that'll help some people where you don't have access to a DMX to get that C1-C2 overhang. It won't be quite as good, but for a lot of patients, it'll be good enough. So thanks so much for watching, guys. You have a wonderful weekend, and I'll see you all back on Monday.